One of the most fun moments I had at AAD 2024 was directing my session, and this is a little biased, Itch Tales, where we talked all about conditions that may look like atopic dermatitis, maybe treated like atopic dermatitis, but they're totally different. And oftentimes we get fooled day to day in clinical practice. And we really took a nice rundown of both eczematous and non-eczematous conditions that may be thought of as itchy, red, inflamed, and therefore be called atopic dermatitis, which you really want to be careful about. So I'd say probably my top two pieces of advice for thinking about the other conditions is number one, just because it's itchy and just because it's dermatitic, don't reflexively say atopic dermatitis. Atopic dermatitis generally does have criteria that make it a diagnosis, but we know that probably AD is a little more expansive than we narrowly used to think about, but at least think through some of those criteria, whatever system you want to use. The UK Working Party, the Hannafin and Riker criteria, the AAD consensus criteria as well. All of those are there to arm you to try to funnel it down to hopefully getting close to an atopic dermatitis patient. Next, if you end up treating someone for suspected atopic dermatitis, and for whatever reason, your response is not what you're expecting, things aren't getting better, you're really getting minimal improvement. In fact, maybe things are getting worse, there's some new symptoms. Don't be afraid to pause and reassess. Atopic dermatitis is indeed a clinical diagnosis, but there are cases where diagnostics can be helpful, both in terms of blood workup and biopsy, if you're thinking about some of these other entities. What are some of those other entities that we covered in our session? Everything from pemphigoid, cutaneous lymphoma, contact dermatitis, seborrheic dermatitis, psoriasis, urticaria, genetic conditions, nutritional deficiencies. All of these can be really common mimickers, and not all of them are going to be just purely based on an eyeball diagnosis. So one of the most exciting things about AAD 2024, aside from all the fun stuff that I selfishly get to do, is the fact that we are one more year moving forward into a new era in dermatology. And what do I mean by that? Historically, dermatology has always been thought of as specialty of topical steroids, oral steroids, generally non-specific anti-inflammatory therapies. And while these still have a place in our therapeutic armamentarium, the explosion in targeted topical and systemic therapies for many of our inflammatory and immunologic diseases has really been clear. And I think it's sort of a call to not only innovation, but for us to really step up our game in terms of therapy to better understand how we get individuals off relatively broad, untargeted therapy that can be prone to a lot of adverse events onto the safest, newest, most targeted options. And so with AAD 2024, I'm really looking forward to obviously the late breaking sessions to talk about some of those newest therapies that are in phase 1, 2, and 3 trials. I also really love hearing about practical tips related to newer therapeutics that are already in practice. And there are many sessions to choose from in this regard. Bottom line, I think that it's up to us to really foster innovation in our specialty. And the number one thing that we can do is make sure that we understand this data, feel confident, and really incorporate a lot of these novel therapeutics into our day-to-day practice.